Thank you all for being here today. My name is Krista, as you know, and I did my capstone presentation on postpartum hemorrhage, so I created a PowerPoint for you guys, and I'm going to explain to you like all my evidence-based practice and everything that I researched over the last couple months. So here we go. So the objectives of the PowerPoint is staging of the obstetric postpartum hemorrhage, reviewing the effectiveness of objective versus subjective staging, identifying nursing interventions for postpartum hemorrhage, and evaluate the changes needed for better outcomes for our patients. So the current issue and why I chose this as my capstone presentation is that there's a delay in identifying and treating postpartum hemorrhage. So essentially, we are not catching it soon enough, and if we're not catching it soon enough, then we're not treating early enough, which not treating soon, or sooner, excuse me, is part of the morbidity rate that they have calculated. So does objective or subjective staging make a difference in the delay? Yes, it definitely does. Now, while objective takes longer the process itself may take more effort and time, it's actually more accurate than subjectively. So if we're just eyeballing it, we're not necessarily getting accurate information, so we don't know what the blood loss is. We're just looking at it and saying, I think it's about this, whereas objective would be, we're weighing pads. We're seeing what the blood loss is. We know how much the weight is in comparison to subjective, where we're just looking at it and saying, this is what we think it is. Postpartum hemorrhages account for 11% of maternal deaths in the United States, according to ACOG. And of those 11%, what the research is saying is that the delay in treatment is contributing to the 11%. So the importance of early identification, the effectiveness of the treatment has been shown to improve when identification of the hemorrhage is sooner. The qualitative measurement has been proven to be more accurate than subjective measurement or estimated blood loss. So obviously when we do vaginal deliveries, it's more of an estimated blood loss until we start seeing those patients postpartum losing blood in the pads. So that would be after delivery, you may get that estimated blood loss from the midwife or the physician, but after that, it's our job to be weighing the pads, doing our part of doing the objective thing in that situation. And then of course in the OR, it's all objective because we have a suction machine that's calculating all the blood loss, and we're able to decipher what's blood loss and what's amniotic fluid, what's when they're irrigating, that kind of thing. So we talked about the difference between subjective, which is an estimated blood loss, and objective, which is qualitative. So it's very specific and accurate. So the staging methods, essentially from stage 1 to stage 4, according to ACOG, this is what we have. So stage 1 is blood loss greater than 1,000 milliliters for a cesarean delivery, and greater than 500 milliliters for a vaginal delivery is going to be your stage 1 hemorrhage. So this is going to be, you're going to be treating with uterotonics initially, and then we can go on to stage 2, so continued bleeding, and it's up to 1,500 milliliters with treatment of stage 1 uterotonics, so we're still bleeding. Stage 3, continued bleeding, greater than 1,500 milliliters with abnormal vital signs, with treatment of stage 2 uterotonics and blood volume replacement. So essentially what we're doing is not working. And then stage 4 is obviously what we never want to get to, which is cardiovascular collapse. So when we break down these stages, you can see how important it is to know exactly how much the blood loss is, because if you don't know, then you don't know what stage you're in. So you don't know how to effectively treat and when to move on to the next stage. So our nursing interventions for us on the job are, we do our risk assessment scores for the antepartum mom. So as soon as they come in, we're doing that risk assessment that's in our charting system. We do a risk assessment score for the postpartum mom. So they should be getting 2 for the length of their stay of those risk assessments. 1 before delivery, 1 after delivery, based on the delivery. So it may change because you can hemorrhage, as you guys know, up to 12 weeks after delivery. So we also want to utilize objective measurements for blood loss. So that means we need to be proactive when we notice that there's quite a bit of blood loss, more than what we're used to seeing. We need to start weighing the pads. We need to start doing what we can do to stay ahead of it. Having uterotonics easily accessible and ready. So you guys know, every time we admit a patient, we pull out that little emergency medication kit out of our Omnicell, and we have that in every single room, ready to go, so that if we need it in an emergency, it's there. And if we don't, then we put it back. Knowing your policies in regard to treatment, of course we all know our policies and procedures based on this. We do the risk assessment tools. We do the objective method of calculating blood loss at our hospital. And knowing how to initiate MTP, which is mass transfusion protocol, as you guys know, when necessary. So when we're getting to that 1,500 or that 1,000 level, we need to go ahead and be prepared. Call the blood bank. We need blood now. Or we could need it any minute. So they can go ahead and get it prepared for us. And then, of course, as you guys know, when we do our risk assessment tool, we automatically do a type and screen on every patient, so we know what their blood type is. If they have a really high risk for postpartum hemorrhage, the blood bank is already aware and they have that blood for us. So that's another reason why we should be doing our assessment tools. So for this particular capstone, so they wanted us to do a PICOT question. So that stands for Population, Intervention, Comparison, Outcome, and Time. So my entire capstone was around, in a postpartum hemorrhage patient, how does staging and identifying the risk factors compare to estimating blood loss and not following any rubric of staging affect the number of maternal deaths during the postpartum and recovery period? So based on the literature that I reviewed, quantitative measurements have proven to be more accurate than visual estimation. Visual estimation is more likely, to overestimate when volumes are low and underestimate when volumes are high. So off in both ways, in the wrong way. And the outcomes have not been proven to be higher or lower in regards to mortality when using quantitative versus estimated. So the implications for our nursing care, we're going to be checking our risk assessment scores. Because we're already doing them, we're going to be checking them. Check them every shift. They can change throughout the stay, like we talked about. It could be before or after delivery. We're going to educate our patients. This is how much bleeding you should see. This is what it should feel like. This is what we're looking for. And if that's not happening, we need them to communicate with us. We know how finicky it can be in the postpartum period. A lot of moms don't really want to be bothered. They want to focus on their baby and they don't really want you in there, but we have to do our job in making sure that they're safe. Knowing your patient's history. So you guys know our policy is if they have 2 prior C-sections, they're getting 2 IVs, 2 large bore IVs, 18 gauges, no matter what. If they have a postpartum hemorrhage in their history, they get 2 large bore IVs because we want to be prepared for that. We want to know their history because if they have a history of a postpartum hemorrhage, then we need to have blood ready for this time. We want to prepare for the worst outcome for every patient. I know that's unfortunate, but it's just the best way to be prepared. And like we said, identifying it sooner is how we treat it sooner. And the last one is inform the delivery provider of any pertinent information. So all those things that we just talked about, y'all know we tell the providers ahead of time because they may not look at it or they may not have had time to see it, but we have. So we need to make sure that we communicate that and that we're all on the same page as far as delivery is concerned and the postpartum period. So recommendations is to use the quantitative measurement system to ensure accuracy. Although there is more research needed for morbidity rates, the quantitative measurements are proven to be more accurate. And continue to educate yourself on the latest research available. So you guys know we are always getting, education sent from our clinical advisor, and we're always getting up-to-date information. I know most of us are getting emails from ACOG and the ANA and, all kinds of different resources. So, and that's my references. So thank you guys so much. Do y'all have any questions? All right, thank you.